Bankart repair the arthroscopic way. So what should we take into account when we are doing? So this is one of my very older presentation when we started doing Bankart repairs. So for the past, we have learned we used to do putty plat, open Bankart, open various procedure, boy chef, and all those things we were doing open procedures. But we have realized that we were trying to find a simple, effective, and reproducible procedures complemented and facilitated by Rehab, minimal bone loss, and acceptable complication rates. So these were the procedures. This is the procedure that we were looking for, that we came in the form of an arthroscopic Bankart repair. So typically, as Harjovan said, that the instability is the anterior, and what is Bankart? It's a lesion of a labrum. It's a group of injuries of a labroligamentous complex located from 3 o'clock to 6 o'clock position when we look at the glenoid in a clock way. So it's, as you can see, it's from 3 o'clock to 6 o'clock anterior, and we can have a posterior lesions too. Types, when it's a simple labral tear, it's a soft tissue Bankart that we see more often associated with a small chip when we call it an osseous Bankart. We can have a Perthes lesion where when we go inside the joint, it looks like a normal labrum. When we probe it, we can actually detach the periosteum and the capsule, and then it is called a Perthes lesion. ALPSA is another common variant that the beginner should look for, that if we don't see the labrum is somewhere below, so we should try to see from the superior pulton and try to detach it, elevate it, and bring it above. So we should try to identify where the labrum is, and can be associated with a cartilaginous lesion, which is a flat glenolateral article defect. So Hill-Sachs, again, the Harjovan has very nicely told, it's a impaction. Every instability is a bipolar region. That's what we believe in most of the traumatic instability, traumatic dislocations. And we have to take care of both the anterior as well as the posterior, the Hill-Sachs component, when we decide whether our soft tissue Bankart repair will be successful or not. So the treatment has evolved over the past few years in terms that we now better understand that it is not just the double breasting of the subscap. All that is we don't have to just prevent the head from dislocating out, but we have to treat what is actually damaged. That is the labrum. So if the labrum is torn, then we have to retension and repair the labrum so that we have a good proprioception. So the patient feels that everything is normal inside, and we can really go ahead with all the sporting activities he wants to do. And the technology, we have very good anchors now. We have all sorts of anchors, thin anchors, which creates a very small hole on the glenoid, and the surgical techniques. And over a period of time, I think we all have evolved, and we have good number of arthroscopic surgeons who are practicing now. Advantage of the arthroscopic way is, and as with any other surgery, it's a minimal surgical trauma. We can treat everything. We can treat the Hill-Sachs, we can treat the Hagel, or we can treat the slap along with it. And it has lesser soft tissue dissection and the shorter surgical time, and the patient recovers. The movement, the most important thing with the open, that was there with the open procedure, the loss of motion, that is not there when we do it in an arthroscopic way. So what is our goal? Is to restore retention and repair. That is what is the aim. So whatever is, as with an ACL or knee lesions, now in the shoulder also do, it is restore what's the anatomy. Whatever is torn, where it is torn, just repair that thing. So if the labral is torn, stitch the labrum to the place where it was there. If the capsule, along with that, you retension the capsule and restore the length of the glenohumeral ligaments in an arthroscopic procedure, so that the patient has good proprioception. Patient feel better that everything is normal inside. So that's a normal, on the left side is a normal labrum, and that's how when I probe it, the labrum is torn. That's how the Bankart lesion looks. Again, it will be discussed again and again. This is how we have evolved in last few years, that we have started doing lots of remplaçages. I think Dr. Shekhar will also tell about. For a successful Bankart repair, good results, we have to look for the defects on the glenoid side and on the Hill-Sachs. So if it is less than 25% as by the Toei and Bankart, it's on track. Then go for an arthroscopic Bankart repair. If it is off track, add something to it. Dr. Shekhar will tell. If it is more than 25% on glenoid loss and on track, then we can go for a Latarjet, and more than 25% off track, go for Latarjet, Remplissage, or a humeral bone grafting along with it. But this is an old study, I think 2012 it is. So now we are accepting less and less bone loss on the glenoid side. So, and some studies have stated that if it is 13% or more loss in an contact athletes, we should go for a Latarjet in those. So we should know what exactly we want to do. So good patient selection and the surgical technique is very important. Do a detailed examinations. Look for the number of dislocation. If it is more, if the patient is able to reduce himself, go look as was discussed earlier. Go for the CT and evaluate the patient pre-op. What exactly you want to do? Want to do an arthroscopic way, or you have to add something to it? So contraindications. So we have a significant bone loss, gross capsular insufficiency, voluntary dislocators. So we try to be a little bit reserved in a simple arthroscopic Bankart repair when we do look for these conditions. Principles are, we have to mobilize, release the labrum so much that when we repair it, we have a tension-free repair, so that the repair doesn't go off when the patient is awake and when the patient is doing exercises. Use minimum 3 or 4 anchors. Perform a capsular tuck and address for the laxity of the capsule, and do a patient should be a coper. Patient should be ready to go for a supervised rehabilitative program for about 6 months. If the patient is not ready to immobilize himself, not going to follow, then don't go for this procedure. So again, this is one of my very old videos. So looking from the posterior portal, we use 2 standard anterior-inferior lateral, the portal standard anterior and the superior portals. So we can see how much release we are looking from the posterior and working from the anterior portal. You can see how well we release the labrum so that we have a tension-free repair. And this one anchor is put. So these are the older times. So the first anchor is at around 530. This is at the level of bare spot. You can see this is the bare spot. So that is around 430. And we should, again, as I emphasize, we have to do a tension-free repair. So we should release it properly. And as you can see, we are shuttling the suture. While we are shuttling the suture, look at the anchor. The eye should be at the anchor. There should not be movement of any sutures on the at the anchor side. So we are not offloading the anchor. So we can take a good wide little bit of capsule and a labrum. And the aim is inferior to superior shift. So we are retensioning the labrum as retensioning the capsule, the glenohumeral ligaments from inferior to superior area. So we are aiming the side to side repair as well as inferior to superior shift. So you can see in this anchor is the second anchor at the level of around 430 position at the level of bare spot. So this is the classical way we do when we have a simple soft tissue Bankart lesion with us. So that's how it, now we are tying the knots. You can see we can have a good bumper effect. The anchors are placed on the face of the glenoid 2 to 3 millimeter inside, so that we can have a good bumper effect. So nowadays that we have, these are those, as I told you, we have stopped using metal anchors. We are most of the times, we were using bio-composite anchors. Now we have switched on to the all suture anchors. So those are the anchors, because those anchors are very thin and they don't damage the cartilage that much. So that's how the third anchor is put. Third anchor is at 3 o'clock. 3 o'clock is basically at the level of the upper border of the subscapularis. So 1, 2, and 3. So we can have a good chalk clock effect. You can see the bare spot. One anchor is above the bare spot, one below, and one it is at the level of the bare spot. So that's how we do. And again, we look for the concomitant pathologies. So knotless anchor, we used to do lots of knotless repair. Now we use most of the times when we are doing a bony Bankart, we put a knotless anchor below and above and a knotted at the level. So that's how we do now. But this is just for the sake of showing that we can do the repair in a knotless way. So we have put 2 anchors already. We have passed the suture lasso through from the anterior portal, retrieving from the superior portal, and we pass a wire through it. And we pass a fiber wire, and then we put a knotless way. principles of the repair is very important. We have to see that there is no much of a bony loss. I had videos of that. I think Dr. Shekhar will show this. We have to intraoperatively assess how much bone loss is there after assessing onto the CT scan before, and mobilize the tissue well. You can see how well the labrum is coming onto the face of the glenoid, creating a bumper effect as we hammer the anchor in. So this is a push lock anchor that we used to do, and we still use in selected cases these types of anchors. So that's how the repair is. And again, that's a remplissage. I think Dr. Shekhar will show. We have to look for, I'll just make it forward. So we put in this video, I just want to show you want to do a remplissage. So first put the remplissage anchors and take a tissue, bite along with it, and then do a classical Bankart repair. So this is how again the Bankart repair is being done. So the idea what I want to show with this video is that you have to assess the concomitant pathology. The soft tissue Bankart repair will be successful only when you treat the concomitant pathologies along with it. I think I'll skip this. So post-operatively, patient we generally immobilize for about 4 weeks to 6 weeks. Patient is allowed to do normal activity like brush, put tying a belt, and ABR is avoided. At around 4 weeks, we start doing the external rotation. Aim is that for first 6 weeks, we have some immobilization, and about 6 to 12 weeks, we aim is to gain full movement, and after that, we gain full strength in about 6 months' time. That's how we start then allow to play. So with the advancement of techniques, recurrence rates are now comparable to the open procedures, but the arthroscopic technique addresses the actual pathology, the Bankart lesion. It also enables to address the concomitant pathologies, and with meticulous techniques, most of the bony deficiencies can be managed. So one has to be careful while doing the Bankart. When we put in hardware inside, the anchor has to be put below the arterial margin with a firm purchase in the subchondral bone, so that the anchor is not pulled out, and also it doesn't damage if it is proud, then it will damage the overlying cartilage. You have to place 3 anchors at least. That's what we believe. 3 or more anchors has to be put below the 3 o'clock position. If you try to repair above the 3 o'clock position, you will end up in having a loss of external rotation. And the anchors are, first anchor is around 530, then at around 45 degree to the arterial surface. The second is at the bare spot, and the third is at a level of 3 o'clock. When you have an ELPSA lesion, look from the superior portal, mobilize the tissue well, bring the entire capsule and tissue to the level of the joint, so that when we repair it, we don't have a repair in tension. So we have a tension-free repair. And if you have a haggle, you have to repair that thing. Hill-Sachs, you have to tackle that thing. So if the bone loss is around less than 15%, we can just go for a simple soft tissue repair. 15-25% is a gray zone. We have to you have to carry out which repair you want to do, a bony repair, bony Bankart incorporation within remplissage, or a lethargy, and if more than 25%, I think we have to go for a glenoid bone reconstruction. So the success for the arthroscopic Bankart is the correct patient selection, good surgical technique, treat the associated lesion, and the practice. Of course, the practice is the most important aspect of it. Thank you so much.